So this is my presentation. My name again is Magnus Chun. I'm a fourth-year medical student at Tunic University School of Medicine in New Orleans, Louisiana. Thank you to the SMA for hosting this amazing conference. So today I'll be presenting to you a rare case of disseminated MSSA bacteremia without endocarditis. And so this patient was a 48-year-old African-American male who presented with a 2-day history of abdominal pain and shortness of breath. Interestingly, he was actually initially asymptomatic when he landed on a domestic flight here into New Orleans, however, experienced symptoms only after eating some gumbo. His past medical history included hypertension and recurrent boils in his axilla. And on physical exam, he was hypertensive to 140s over 80s, and he had some abdominal tenderness to palpation, as well as we noticed some gingiva, erythema, and swelling. We were able to get some EKG that shows sinus tach with S1Q3T3 pattern, an ultrasound of the lower extremity that showed a QDVT, and we were able to order a CT abdomen pelvis for his abdominal pain that showed actually a faint nodule, and also pulmonary emboli as shown in figure 1. We ran blood cultures, and initially it was positive for some gram-positive cocci in clusters, later identified as MSSA. So we initially treated this patient with oxygen and heparin for his septic pulmonary emboli. We initially also started empiric bank, however, later transitioned to cefazolin when MSSA was identified. Unfortunately, after 24 hours, this patient decompensated and required intubation and admission to the ICU. We repeated the CT chest that showed an empyema, as shown in figure 2. And we drew out some fluid that was positive for MSSA. Luckily, we were able to insert bilateral chest tubes that and achieved source control. However, unfortunately, overall, he stayed in the hospital for about a month with the polyfocal empyema, preorbital cellulitis, and also septic facial vein thrombophlebitis, as shown in figure 3. And then the patient improved clinically and was discharged on a 6-week IV course of cefazolin at his home in St. Louis, Louisiana. St. Louis, Missouri. And so in discussion, patients who are MSSA positive can initially present asymptomatic, but can decompensate pretty quickly if the source is not identified. Unfortunately, we still actually have not figured out the source of this MSSA bacteremia, which is a very important thing to do for any patients who have any type of infection, let alone MSSA. It could have been his infected axilla boil that actually resolved prior to admission. So he has that history of boils. It could have broken in the past and went into the bloodstream and presented asymptomatically. It could have also been his periodontal abscess that we noticed on physical exam. He did have some erythema, some gingiva erythema, and so again, if that abscess was able to break, that could seed the bacteria into the bloodstream. And then finally, he did present with symptoms after he ate some food. Now, there has been limited cases of MSSA bacteria from reported enterocolitis. And so it is very rare for that to occur. We also ruled out a couple of things, such as endocarditis. His TTE was unremarkable, didn't show any vegetations. In terms of IV9s, we actually placed it after the culture was going positive, so and that's likely that it came from a catheter or an IV9. It did have the history of the open reduction internal fixation of his left arm. However, we were able to adequately source control it with bilateral chest tubes. And so we're still kind of unclear about what the source is. So our recommendation for any patients, regardless of if it's MSSA, MRSA, any type of infection, is to really do a thorough physical exam to really identify, are there any rashes on the patients? Are there any, history that the patient had in the past? And do a ton of imaging to try to figure out what's going on. Because if we don't find that source quickly, patients can decompensate like in this patient. Thank you for your time, and I'll open it up for any questions at this time.